Medurstand Understanding Medicine.
This is Professor Aziz Rehman from Medurstand-Understanding Medicine. And in the last two videos, I talked about chronic kidney disease. And today we're going to talk about one of the main treatment, which is called renal replacement therapy. In previous lectures, I did cover conservative treatment, some dietary principles, some medication which are used to preserve kidney functions and also to lower down the load on the kidney. But many patients, they actually end up in CKD5 and they need some type of renal replacement therapy. So this lecture is of course brief, and the target audience is postgraduate student who is specializing in internal medicine, not the fellows of nephrology. Of course, they would need much more detail and perhaps they already know more than this, but this is for undergraduate and postgraduate students and also for general physician, the family physician, to update their knowledge. So, introduction, what is renal replacement therapy? As the name says, it's a technique of replacing kidney's function. If kidney is damaged very significantly and almost irreversibly, then we have to save life to provide kidney functions through some artificial method, because kidney is absolutely essential for our daily functioning, and no body organ can work without kidney function. So we have to provide some kind of renal replacement therapy if our kidneys are not functioning well. So there are three types and I will go through them and will define them and will discuss their principles, their indications and their pros and cons. And at the end I will give you the summary. So first of all, hemodialysis, and then is peritoneal dialysis, and third and perhaps the best is kidney transplantation. Now some authors would not include kidney transplantation in renal replacement therapy because that is actually a replacement of kidney itself. But I think for the sake of completion, I would cover kidney transplantation also briefly here. So there are three main methods of renal replacement therapy. Now, I think in medicine, if you have more than one options, that means all of them has some pros and some cons. That is why all three exist. Now, let's go through them one by one. First of all, hemodialysis. Now, hemodialysis is the principle, the indications of renal replacement therapy, particularly any type. I think I just briefly mentioned, but let's do them again. Complete and irreversible loss of kidney function for whatever reason. All cases of CKD5 would probably need this, and some people with acute kidney injury, they have gone into very advanced renal failure, although there is hope of recovery, but to buy time for recovery, sometimes we have to provide renal replacement therapy in acute kidney injury also. So those are the two indications. First of all, let's talk about hemodialysis, and as the name says, hemo is blood, dialysis is clearing, the process of clearing. Now it's a process where dialysis machine is used and a special filter called dialyzer, and this is the one is used to clean the blood. Now first of all, you have to have access to take blood from the patient and then bring it back. Typically blood is taken from the artery because that is high pressure system and you need some pressure for blood to go to the machine, and then machine will pump blood back into a vein. Now this could be done like this, or many times when we do hemodialysis on long-term basis, we actually create a arteriovenous fistula. It's like combining radial artery with vein so that you have a high pressure vein which can be used both as artery as well as vein. So I think it's easy to puncture, and there are so many veins, so you don't actually have problem, whereas an artery is only one. Puncturing it repeatedly would be difficult, and there's a risk of thrombosis. So blood is pumped into the machine, and machine has this special filter which is disposable. Now this filter actually consists of a very long coil of a tube, and tube is such that is permeable to water and many solutes which you want to remove. So inside that tube, which is actually very long, coiled up like this, like a roll of fiber, so the blood flows within that tube, and outside there is fluid which is called dialyzer fluid. Now this fluid does not have those substances which this blood we want to remove. So against concentration gradient, creatinine, urea, urates, and other all toxic waste products, other nitrogenous products will move from within the tubules to the outside to the dialyzer, and this dialyzer fluid is then removed. So there's actually much more technical detail. I'm going to avoid that. To be honest, I also do not know that detail, because as an internist I think we need to know the principle, and that we are going to cover in subsequent slides. Now this is how the machine looks like. You can see the patient is lying and the blood is coming to the machine. After filtering, it goes back, and typically the session is for 3 to 4 hours. Indications of hemodialysis. Of course, one in the background there is end-stage kidney disease or acute kidney injury with complete renal shutdown, but with some additional features. When we feel that it is now a compelling reason to provide renal replacement therapy. So in that background, if somebody has severe metabolic acidosis, severe metabolic acidosis can kill a person fast. So that would be one indication of hemodialysis, because hemodialysis of all the three types works the fastest and is most efficient. So I think hemodialysis should be used in severe metabolic acidosis. Similarly, persistent and severe hyperkalemia. Hyperkalemia can also kill suddenly by causing lethal arrhythmias without any warning sometimes. So we cannot sit on hyperkalemia, especially if patient has got complete renal shutdown, there is no urinary output. So hyperkalemia would be considered one of the indications of urgent hemodialysis. I would not be able to give you exact number because that varies. Somebody with potassium of 9 may be reasonably stable. Another person with potassium of 8 or 7 may be very sick. So the decision is made on case-to-case basis. Volume overload, unresponsive to diuretics. One of the problems in renal failure is volume overload, because kidney has problem excreting water. So there may be water retention in the form of pulmonary edema, in the form of pleural effusion, ascites, brain edema. So in that situation, if furosemide or other diuretics are not working, then we have to do dialysis. In this case, the special technique is used where preferentially water is removed, because they use this pressure gradient to remove water more rapidly than usual dialysis. Then symptoms of uremia. If you remember the last lecture, uremia could be very symptomatic. One may be unconscious, having seizures, having difficulty breathing, there may be pericarditis, there may be encephalitis, there may be other problems. So all those symptoms, of course, all this in the background of chronic kidney disease stage 5 or acute kidney injury with complete renal shutdown hemodialysis is definitely a very good way of saving these patients. Principle of hemodialysis: blood is taken and sent back through a vascular access. Vascular access is usually an artery or an arterialized vein by arteriovenous fissura, or sometimes a catheter is passed in the saphenous vessel or some other vessel. So I think depending upon the time available, you could use any of those accesses. On long-term basis, we need an arteriovenous fistula, but in the short term, we can use catheter in the artery and the vein. And blood is pumped from the body to the dialyzer, where waste products are and excess fluids are removed. Basically, following the principle of physics and chemistry, because the blood has got lot of creatinine, urates, sulfates, phosphates, acids, and dialysate does not have any of those. So across the concentration gradient, all these waste products will move to the dialysate, and that dialysate, the dialyzer fluid will be changed. So this will be run in cycles. Clean blood is returned to the body. Now, to my understanding, this so-called clean blood may not be as clean as the one we have in our renal vein, because kidneys are extremely efficient to clear all these toxic substances. Hemodialysis may be close, but not exactly an exact replacement of a normal kidney. So typically perform 3 times per week and 4 hours per session. Now this is important. Patient usually goes to the facility where this dialysis is possible 3 times a week and 4 times every time. And this is to allow fluid and other toxic substances to be removed and brought down to a safe level. Then in the interval before the next dialysis, all those toxic substances built up again, fluid accumulates again. Typically patient gains weight 2-3 kg by retaining fluid, and then next dialysis is done. Now from this you can understand that the body chemistry does not stay at a stable level. Before dialysis, all these toxic substances are high, and after dialysis they will be low. So there will be a lot of fluctuation in patient's condition also. So let's now discuss pros and cons of hemodialysis as a technique of renal replacement therapy. Pros: it is very efficient in clearing waste products. Now in emergency situation, like I said, hyperkalemia, acidosis, complete renal shutdown, and volume overload, this is the best way of going hemodialysis. Then regular monitoring by healthcare professional is available, because this is always done in the hospital setting, and patients' vitals are monitored because many complications including hypertension are possible. So I think this provides the option, the facility of continuous monitoring, and patient would feel safe and assured. And it is suitable for patients with limited home support. As we discuss in subsequent slides, in peritoneal dialysis you would require the assistance of somebody at home. There may be somebody who does not have that assistance available at home. For that person, hemodialysis may be preferred option. Now let's talk about the cons. It requires vascular access. Now vascular access, number one, this fistula formation, you need to have a small surgery, and it takes about 6 weeks for that fistula to mature to be able to use for dialysis. For 6 weeks you will have to use direct catheters. So, and in some cases, because of atherosclerotic arterial disease, the access may not be available. So there may not be any vessel, any artery which is suitable for dialysis. So that could be a cause for hemodialysis. And the fistula may also sometimes close and clog up. Can be time consuming and physically taxing. 4 hours on the bed, and then of course 2 hours maybe on both sides, going to the hospital, coming back. So I believe it is like one whole day's procedure for that person. I don't really think that person would be able to do any other work on that day other than some rest after the dialysis. And risks include infection, of course. Whenever there is invasion of artery or vein, there is a risk of infection. Then hypotension, you remove lot of fluid, and there is I think you need to understand the principle also. One thing, that in hemodialysis we create an extra corporeal circulation. So patient's heart has to pump significantly more blood because the extracellular compartment is expanded by several liters. So because of that, there may be hypotension and there may be some other vascular complications. So these are the cons. So in every patient, we consider pros and cons and decide if hemodialysis is the best option for that particular patient. Now let's now discuss the second form of renal replacement therapy, that is peritoneal dialysis. Peritoneal dialysis has got actually several types. The most conventional one is not being done very often these days, in that in acute situation, patient is admitted in the hospital and a fixed catheter is passed in the abdomen, and patient will not be able to get out of the bed for 72 hours because it is the fixed rigid catheter. A lot of difficulty for the patient, but this used to work fine for acute situation. Now they have come up with better technique, and now peritoneal dialysis is done in ambulatory patient because flexible catheters are used and special techniques are used, and patient can actually do this at home or also sometime in the hospital. So peritoneal dialysis is a treatment that uses peritoneum and a cleaning solution called dialysate to clean your blood. In hemodialysis, I said there is a cartridge consisting of a long tube, inside blood, outside the dialysing fluid, and the toxic substances move from within the tube outside. Here we use the peritoneum as one chamber, one large chamber which can hold 1 to 2 liters of fluid, and the entire capillary network of the peritoneum, the lumen of the capillaries of entire peritoneum as another chamber. So collectively that will also make a big chamber. So the blood in the capillaries, the toxic substances in the capillaries will move to the fluid in the peritoneum. And this is the principle. And then the peritoneal fluid, which is instilled actually, as I'm going to show you, that is removed then frequently. So indication of peritoneal dialysis, patient preference or convenience, because this can be done at home, and sometimes patient may prefer the peritoneal dialysis. It may be more demanding on patients but maybe more expensive also. The patient has to have some facility at home, some help at home. So if that is available, this could be the preference of the patient. Lack of vascular access for hemodialysis, that would be another indication. Patient with residual kidney function. Now if you remember my earlier slide, I told you hemodialysis is much more efficient, but if somebody has some preserved kidney function, his kidney functions are still there, maybe his GFR is like around 15, that is significant but not enough to sustain life. So for that, less efficient type of dialysis like peritoneal dialysis may be a better choice. Less cardiovascular strain, because in peritoneal dialysis there is no extra corporeal circulation, there is no additional load on the heart. In fact, heart is slightly offloaded when fluid is removed. In fact, one of the indications of peritoneal dialysis is acute pulmonary edema in the face of renal shutdown. So less cardiovascular strain. If somebody has compromised cardiac function, cardiac failure, I think that patient might not be fit for hemodialysis, so we might use peritoneal dialysis as preferred choice. Now let me now show you the principle which I have just briefly talked about, but in some more detail. Now this is the patient's, this is distended peritoneal cavity. This is filled with dialyzing fluid. Now this has the fluid which is sterilized fluid, which has got glucose and saline and some calcium and those substances which we do not want to remove from the patient's blood. But what we want to remove from patient's blood, they are not there. Like creatinine, for example, and other toxic substances are not there. So this fluid, usually 1 or 1.5 or 2 liters, depending upon patient's size, is instilled and kept there for some time. And that is called indwelling time. Initially, it may be just in and out, but once dialysis goes on, this fluid is kept inside the peritoneal cavity for some hours to allow shift of toxic substances from patient's capillary blood into this fluid. And this fluid then is removed into another bottle which is at a dependent position. So there's a valve. So when we open it, we can change the position to allow blood coming from this bottle into the peritoneum, and then we can make it the other position, the fluid goes to this part. This we keep doing, and this can be done manually or this can be done with the help of a machine. Dialysis is infused into the peritoneal cavity, and waste products and excess fluid pass from the blood vessel into the peritoneum into the dialysate, and the dialysate is then drained and replaced with the fresh solution as I just explained. Now, types of peritoneal dialysis. One is acute peritoneal dialysis, which, as I said, is not done very often. This is done with rigid catheter. In Pakistan, it is still done, but in the developed countries, it is almost now discontinued because better techniques are available. Now they do with a flexible catheter. So this is chronic ambulatory peritoneal dialysis. In chronic kidney disease, obviously you have to do something which works for long-term basis, and it could be done manually or it could be done with automatic machine. So with this, patient enjoys much more freedom and much more independence and autonomy. So this is continuous ambulatory peritoneal dialysis. Patient is sitting comfortably in his sofa and reading something from the iPad and having a cup of coffee, and while the dialysis is going on. And this is manual, and I think this is the bag with dialysate fluid goes into his peritoneal cavity, and then after a certain indwelling time he would open this tube and to allow fluid to drain out. And this will be cycled many times a day, but he can have an independent life at home. So what is it? Some more details. This is a manual form of dialysis that doesn't require a machine. We are talking continuous ambulatory peritoneal dialysis. It of course requires fluids, it requires tubings and catheters and bags, but it does not require any electronic machines because the fluid is put into the peritoneum and drained out just by using simple principle of gravity. The patient lies or sit in the chair, and he manages it itself. He opens the fluid to let the fluid go. He opens that control to allow fluid to go into the abdomen and then drain it out. Then allows the patient to be mobile and maintain a normal life. Patient can adjust the timing, can adjust the place also, and each exchange takes place 30 to 40 minutes. In one go, patient will have to do 3 or 4 rounds, maybe at night. If patient works in the morning, he can manage it in a way that during the night he does this dialysis, and during the day he does his work, or in the afternoon he goes to work, in the morning he does this. So I think he will have to adjust his lifestyle accordingly. But in automated peritoneal dialysis, which is actually an advanced form of manual dialysis, it is like an automatic car compared to a manual car, where most of the things are done automatically. Now, in this, patient is dependent on a machine. The machine runs on electricity and it is pre-programmed, and that program can be changed. Now, patient typically, when he wants dialysis, say after having dinner, before going to sleep, he puts this machine on and program it. So during the night when patient sleeps, this machine will automatically put the fluid into the peritoneal cavity and drain it out. So it will provide more independence. Exchanges are typically done overnight while the patient sleeps. Convenient, the machine handles the fluid exchange automatically. So I think that definitely is an advantage. So pros and cons of peritoneal dialysis. I discussed pros and cons of hemodialysis. So there are pros and cons of peritoneal dialysis also. Let's talk about the pros first. It provides greater patient autonomy and flexibility. This is a great advantage for people who work. So a thing with the peritoneal dialysis, especially the automatic, one can maintain his executive job in a corporate or in a high institution and can be fully productive. So because he uses his time in a way, at night dialysis is done while he has his sleep, and during the day he works. Can be done at home or at work also, and continuous process potentially preserving residual kidney function. One advantage of this continuous process is that it maintains patient's biochemistry in a safe range. Unlike hemodialysis, it doesn't fluctuate too much. In hemodialysis, there's a lot of fluctuation. In fact, many people after a session of hemodialysis, because of shift of fluid, they feel very, very unwell and sick. This is called disequilibrium syndrome, and that is much less likely with this because patient does it more frequently. Patient does it every night, and shift of fluids and solute is not that massive, so patient will feel more normal. Cons: the risk of peritonitis. Although the newer catheters, they are designed in a way that they do not allow germs to enter the peritoneum, but there is actually a possibility that some germs might enter and there may be peritonitis. If there is peritonitis, initially we use antibiotics instilled into the peritoneum or given systemically, but sometime we have to remove the catheter and place another catheter. So it requires patient training and compliance, and may not be suitable for patients with abdominal surgeries or hernias, because you need an intact peritoneal surface. If there are a lot of adhesions, small pocket formation, then fluid drainage will be a problem, so that may not be suitable. I believe in pregnancy, if that rare situation happens during pregnancy, if somebody has to have dialysis, again peritoneal dialysis will not be possible. Now this is about the two types of dialysis. Now we're going to talk about the kidney transplantation, which is the third and the ultimate form of renal replacement therapy. So indication of kidney transplantation, I think every patient with end-stage renal disease, whether the disease is irreversible, I think with no contraindication for surgery, should be considered for renal replacement therapy with kidney transplantation. In other words, every patient should be first considered for kidney transplantation. But kidney transplantation has got many issues. You have to have a donor, and the donor has to be compatible. and then donor has to be willing to donate kidney, and then donor and the patient has to be fit for renal transplantation surgery. So I think all these conditions are need to be met, and it cannot be done overnight. So I think all those patients who are being prepared for kidney transplantation, they would require some kind of dialysis, and those once they have kidney transplantation, then they would not require dialysis, hopefully. So good overall health, except for the kidney. So the recipient needs to have good overall health, except the kidney failure, of course. He needs to have a good heart and lungs to be able to tolerate this surgery. Acceptance of lifelong immunosuppression. After every transplant surgery, we give immunosuppression, which is lifelong, and patients should not be suffering from some disease where immunosuppression is not possible, like HIV infection. That would be a contraindication. Then preferable to long-term dialysis for eligible patients. I think this is definitely an important consideration. So to sum up this part, kidney transplantation is for everyone who can fulfill these conditions. Principle involves the surgical implantation of a donor kidney. This donor kidney can come from a volunteer who is a relative, because the relative is more likely to have a matching with the recipient, and in Pakistani law you actually cannot have kidney donated from non-relative unless all the eligible relatives have been tested and have been found not compatible antigenically. Because human sale is prohibited, so taking kidney from the so-called unrelated donor is actually buying kidney. It requires immunosuppressive medication to prevent rejection. This is very important. And transplanted kidney takes over the function of filtering blood, and just like a normal kidney. You know, we are blessed with two kidneys. Both function as one unit, and for a normal person, one kidney is good enough. If you take out one kidney, in great majority of the donors, the other kidney will take over. With time, it might enlarge a bit, but patient will not have any problem. So that is why donor kidney is taken. Deceased kidney would be another option, and kidney from an animal called xenograft is perhaps the greatest option. And recently there have been a trial, and there was a case in the New England Journal of Medicine that they done a successful xenograft, and patient is alive so far on immunosuppressive therapy. So if that becomes successful, I think the commonest source of the kidney would be an animal. But so far in Pakistan, it is living donor. Those patients who have given consent in their life for organ donation, and when they die and when they have brain death, their kidney can be taken immediately, because you have to take it out immediately. Only then it will be able to be grafted to the other person. So pros and cons of kidney transplantation: best quality of life and survival rates. This is perhaps the best reward. Patient can be fully independent, enjoys life like just normal person, and life expectancy may not be equivalent to another person who does not have kidney problem at all, but it would definitely be better than those who go for hemodialysis or peritoneal dialysis. Freedom from dialysis and better overall health outcomes. These people, there are people who are on peritoneal dialysis and they're professional athletes. They play competitive game. They run institutions. So I think this definitely is very, very good. In the cons, we need to have a donor. Donor has to be healthy, volunteer. His kidney function must be ideal. His other organs must be normal also. And then if that is not possible, then the other donations like from deceased cadaver or the xenograft. It requires surgery, and there is associated risk of surgery. Every surgery has risk, but there's a great benefit. To my understanding, renal transplant surgery is not very complicated, because once the kidney is actually outside the peritoneum, all they have to do is to take out the entire kidney with its vascular connections and put it on the other patient. I think, of course, it's an advanced surgery, but still done in many countries like ours. Lifelong immunosuppression and its side effects, of course, you will have to tolerate. Risk of organ rejection. Even if the donor is matched, still there is the risk of rejection, and that is despite immunosuppression, and then some patient may require another transplant, and this rejection can be acute or can occur at some later stage. And I know people who have taken double transplant also. So other than these three renal replacement therapies, patient would need education and life adjustment. None of these treatment is without problem. This patient would require dietary management, because to minimize burden on the kidney and the dialysis. Fluid management, this patient will have to have controlled fluid intake and medication adherence, particularly immunosuppression. Psychological support and counseling would be very helpful, and regular follow-ups for dialysis adequacy and transplant function is very important. And then monitoring for complications such as infection, cardiovascular issues, and bone health is important. So all these would require a lifelong commitment by the patient as well as the physician and the nephrologist and the transplant surgeon and the technicians who do dialysis. So this was about the renal replacement therapy, ladies and gentlemen. Now I'm going to present the summary. Renal replacement therapy is extremely useful to sustain life in those who have lost kidney functions completely. All three types, hemodialysis, peritoneal dialysis, and kidney transplantations, have pros and cons, and in individual patients we decide which one is the best. Generally, renal transplant is the best. Supportive treatment and regular follow-up will remain important, and I think with this we can hope that these patients with complete loss of one very essential function can still live a useful, rewarding, and productive life. With that, I'd like to thank you for watching this video. This has been Professor Aziz Rehman from Medurstand-Understanding Medicine. Please join me in my next lecture, which is going to cover other aspects of chronic kidney disease, and particularly I'm going to talk about the diet. Thank you.